Okay, so on the level 3 course in Alcorcón, Madrid, yeah, we have a course participant who has shoulder pain. Yeah. He has right-sided shoulder pain. It's a localized pain anteriorly, and then sometimes it spreads into the deltoid area. It started around 2 years ago when he did a one-arm pull-up. Yeah. Something snapped in the shoulder, and there was a period where he had a lot of symptoms, inability to lift the arm. Okay. Now, since then, the symptoms have improved. Now the pain is no longer constant, it's intermittent. But he still describes this pain. Now, from the causing incident, you think shoulder. From the localization of the symptoms, you think very shouldery. Now, what activities still bring on the pain? Overhead activities with climbing. He climbs 7C8A, which is quite high level of climbing. But he also describes problems reaching behind his back. So because he has both symptoms, overhead and behind back, again, it sounds very shouldery. Now, when we do the inspection, we see an atrophia of the infraspinatus muscle here, yeah, which is indicative of a longer standing problem. So if I palpate the meat, there is clearly less meat on the right side. If I tap on the muscle, can you hear the difference? So clearly there's less muscle. So let's quickly have a look at the muscle function test. Mantén esta posición, por favor. Now, watch his teres minor. He has a quite nice teres minor on the left side also, which is very typical for climbers. Now look on the right side. Mantenga. Can you see he cannot hold the position? And you beautifully see his teres minor. So he has a weakness of the teres minor. Okay? So then let's have a look at the active movements. I'm just going to look at a few, yeah? Can you do bilateral flexion, please? Okay. Now, if you look at the creases here, the creases on the left are a little bit deeper than on the right, which is indicative, again, that the right shoulder is slightly stiff. If I look at the upward rotation of the scapula, it's perfect. Yeah? So there's sufficient scapulothoracic movement. If I give just a little bit of overpressure on the left side, I can move a little bit further. If I do it on the right side, I cannot move it further. And it's uncomfortable. Okay, you can go down. So his flexion is subtly limited. Okay, now can you put this hand on your back and go down? Take the other hand. Okay, now again you can see the massive atrophy there. And we can understand why he has problem reaching behind his back. Go down. So the active movements fit with the CO asterisks. So now let's have a brief look at his lateral rotation. If you look at the lateral rotation here, he's very good. He has like 75. And here, he has 90. So that is very good. But if we go here, because if he has 1945, he should have 110 there. Here he has 80. So this is not the classic pattern of a frozen shoulder type. Yeah? Because then he would be limited here also. So let's have a look at his medial rotation on this arm. And here he has his 45 degrees. Here he has 5 degrees, which would be typical for posterior tightness. So when I then fix his scapula and scaption, I look at his horizontal flexion, he doesn't even reach the sagittal plane. So this would always all fit with a posterior tightness. Okay, now, can you lie on your back? So we have to confirm that the passive physiological movements fit with the active movements. So the medial rotation is 10, 15. Then the horizontal flexion, he doesn't reach the horizontal. Now let's have a look at your flexion. This is a test, you can only do that if the shoulder is not very painful. But it's a nice way of directly comparing left to right. Maybe it's even better if I do it like that. So I'm controlling the rotation here. And can you see the difference between left and right? Yeah? There's clearly a massive shoulder limitation. So we did the inspection. We palpated the muscle bulk. We did the active movements. Specific muscle function test of infraspinatus. We confirmed with passive physiological. So now we're going to do the special test. Now, what is the special test for posterior tightness? In 45 degrees of abduction, do a medial rotation. So it's important that the upper arm is in the frontal plane. I place my middle finger on the coracoid, my index on the humerus, and now I do a medial rotation. And can you see how the humeral head goes forward? So, because the posterior capsule is not long enough, you get a roll. Now, the last time you saw it, a jumping. Can you hold that? So what happens is that as I rotate, the humeral head rolls onto the labrum and goes forward. And then the last time it jumped back. So that's very classic for posterior tightness. Okay, so you want to be careful not to provoke that too often. So now, as a final proof, you have to do the accessory movements. So you compare the accessory movements on the good side to the accessory movements on the symptomatic side. Now, and what I get here is mainly scapulothoracic movement. I do not get glenohumeral movement. So now I've filled my cluster of indications of posterior tightness. Okay, what of course would then be the final proof? If I do some techniques to mobilize the posterior tightness, and then reevaluate. So I can do some gentle AP mobilizations. I like to do that with my whole hand, not to get too much local joint irritation. ¿Cómo no? And you can change the position of abduction. Yeah. Then you can slowly move more and more towards horizontal flexion. You can also decide you want to mobilize medial rotation, but you want to make sure that the humeral head does not roll on the labrum. So very gently with my lower arm, I'm in front of the humeral head. Now, please observe the amount of rotation I have now. But if I go a little bit further down, I immediately have more rotation. So I can adapt the position of abduction scaption to the intensity I want the technique to have. Another way you can mobilize, you can decide to mobilize with horizontal flexion. But of course, then you need to fix the scapula. Everything okay? So, I have a lot of options here. I can fix the scapula and mobilize into horizontal flexion. Or I can move into horizontal flexion and then mobilize the scapula back. Or I can combine the two. Al mismo tiempo, I'm mobilizing into horizontal flexion and pushing the scapula back. Is okay? Or I can then even add an accessory movement on the humerus. So with my body, I'm mobilizing horizontal flexion. At the same time, with my right hand, I'm pushing the scapula back. And at the same time, with my left arm, I'm doing dorsolateral glide of the humeral head. Let's just do a quick mini reassessment. Relax. It's a little bit improvement, not a lot, but we would have to work a little bit more on that. Let's have a look at that. You see a difference there? ¿Todo bien? I'm always monitoring his eyes. because the first onset of pain you can usually see in the eyes. Relax. Yeah. Relax. Mm-hmm. Can you stand up? Can you do a bilateral flexion again? Okay. Now, let's have a look at the muscle function test. You feel a difference? What's the difference for you?
I'm strong.
Yeah, he has more strength. So that actually means that there's a lot of AMI, arthromyogenic inhibition there. Okay, thank you very much.